Friends, colleagues, welcome to this webinar, which was conceived by Christa Wichterich, and JNU is formally the host within an arrangement which is known as Global Partnership Network. Possibly it is one of the most interesting, unique initiatives in not only academic setting, but trying to think of a very substantive partnership between academics and civil society organizations. This network consists of 12 universities and 18 civil society organizations, mainly in the Global South, but this initiative is headquartered in Germany at the University of Kassel, funded by the German federal government as their Exceed initiative. Right? It has been functioning since April of 2020. Unfortunately, the first 2.5 years of COVID, we could do very little. But after that, it has been making very, very reasonable progress, trying to make up for the lost time through a series of activities, etc. And in that series, this is one of the programs that we, on request of Professor Wichterich, sort of agreed to host as part of programs for this year. And Center for Social Medicine and Community Health in JNU, headed by Professor Sanghamitra Acharya, was kind enough to take it forward. So, effectively for the India leg of this particular program that Christa envisioned, it is a partnership effectively between Sanghamitra Center and Christa. So let me, on that note, welcome Christa to say a few words about the program itself, this particular, sort of project on which we are having this workshop, this webinar.
Thanks a lot, Praveen. I would like to welcome all of you as well to this seminar, To Stay or To Go, on recruitment and out-migration of nurses from India. This webinar is an important event in the GPN project on out-migration of nurses from countries of the so-called Global South. The Global Partnership Network, GPN, as Praveen said, is a unique network of universities and civil society groups, which wants to provide policy-relevant research in 3 areas: development cooperation, global economy, and knowledge production, keeping in mind that international partnerships have historically been shaped by colonial relations between North and South and continue to reflect them. My name is Christa Wichterich. I am on the board of the GPN after I retired from being a professor for gender politics at the University of Kassel. I consider the GPN an excellent forum to compare issues which are shared by countries from different regions of the world in the global economy. Therefore, I organized this project on the out-migration of nurses from 2 countries of the Global South, Ghana and India, and their recruitment by Western countries. These processes are part and parcel of the so-called global care chains. The aim of the project is to map actors, interests, and power relations in the scenario of training, employment, recruitment, and movement of nurses in each country. The aim of this webinar is to fuel and to fire a public debate about the recruitment and the out-migration of Indian nurses. Last week, we had a webinar on these topics with the University of Cape Coast in Ghana. It was an Acharya, who is a key organizer of the project and was supposed to be the moderator of our session. Sanghamitra Acharya is a professor at the Center of Social Medicine and Community Health, School of Social Sciences at JNU, New Delhi. She taught at the International Institute for Population Sciences from 1990 to 1999 and was director of the Indian Institute of Dalit Studies during 2015 to 18. Unfortunately, Professor Sanghamitra has lost her voice and is not in a position to moderate, but I think she wants to greet us and to welcome us and well wish for this webinar.
Thank you, Christa, and apologies for a very bad throat. I am really grateful to you for rescuing me from this scenario, which I really wanted to kind of moderate. But then thank you so much to all of you who agreed to be in this seminar on a comparatively short notice. And I really appreciate the willingness with which all of you have agreed to be part of this conversation, which I think is very important to take note of, because on the one hand, while India is one of the major senders of nurses, we also experience the shortage of nurses too. So going by that paradoxical kind of a situation, I look forward to listening to the panelists in terms of perhaps the questions which I could have raised and now have shared with Christa, some of their ideas when we want to understand, despite the fact that we see a continuous reduction in the migration rate of the nurses in the country from 33% in 2011 to about just about 23% in 2016, and it's continuing to drip. What exactly is happening, despite the fact that it still remains an important concern that we are interested in understanding? Is extremely perhaps important for us to take on board is therefore that while on one hand we have this stream which is continuously interested in looking forward to the destinations which are beyond the border, perhaps there is some positive indications that as professionals, and on the other hand the way perhaps is reflecting to. And it's fairly well kind of addressed when we look at India as the main nurse sending countries to most of the, perhaps after Philippines, if I recall my data correctly, we do have about 88,000 of these nurses who are sent to ODEC countries, and the main destination, perhaps by virtue of English-speaking advantage, the English-speaking countries like UK, US, and Australia. And I quote one of our panelists, Professor Irudaya Rajan, who says in one of her papers, one of his works, that it's about 640,000 nurses who, as of now, as of 2014-15, were working abroad, working in specifically Gulf countries. So if this is the state of affairs vis-a-vis the data that I'm quoting at the moment, what is it that continues these streams, and what is it that we want to look forward to in terms of the answers that we need to look from the panelists? Stop here, Chris.
Yes.
Over to you for moderation, and once again, extreme apologies for not being able to fit the bill at the moment.
Thank you very much, Professor Sanghamitra, for being with us at least, and we are happy about that and wish you all the best. So then, without much ado, I would like to hand over to our first speaker. That is Dr. Prakasamma. She is a public health professional with a PhD in social medicine and community health from the JNU and advanced studies in international health and epidemiology from Harvard School of Public Health. She founded the Academy for Nursing Studies and Women's Empowerment Research Studies, ANSWERS, Answers, in 1991. She has undertaken studies and interventions through the Government of India and several state governments for restructuring and strengthening nursing education and service. She has been advisor to the Government of India, to the WHO, and other national and international agencies and state governments on public health, nursing, midwifery, gender, and reproductive health issues. So thank you very much, Dr. Prakasamma, for being with us.
So I will be sharing today about the preliminary findings, which will be coming out in the form of a book. And why are we doing this? What is my concern in doing this? So as a preliminary to the presentation, I want to do that. Can I have the slide, please? The first one. Yeah.
Sorry, I cannot move it. Okay.
Yeah. So as I said, this is based on interviews and interactions in October and November till the 22nd with about 120 Indian nurses who migrated to the USA between 1960 and 2010. And also collective reflection of 15 graduate nurses who migrated between 1968 and 99. And here, over the last 10 years, I've been interested in writing narrative ethnobiographies of, short ethnobiographies of nurses. And why am I doing this book or these narratives over the last 10 years mainly, is one thing is to give voice to migrant nurses. This book and this work will give an opportunity to the migrant nurses to express their struggles and successes. And we are looking at it on 4 levels: migration, the process, the purpose, adaptation, achievements, and contributions. That's what we are looking at in this book. Secondly, to give visibility of the contributions of the thousands of Indian nurses who've been working for the last 50 years in the USA. And especially because nursing profession and nursing professionals have been successively voted as the most trusted professional in the USA. And the Indian nurses have a huge role to play. And another reason is, for me and for the organization Answers, gender equity and advocacy and autonomy to work have always been the core principles of our work. And with this as the background, I've started doing this work. Christa, can you share the next one, please? So why autonomy for nurses? That is the basis for this whole, the work, the advocacy work and the visibility and the writing that is taking place. One is the right to practice based on years of learning, right to practice independently, distinctly different from all other health professionals, right to be recognized and remunerated, and right to represent, regulate, and govern themselves. This is what autonomy means for Answers. Please, Christa, the next slide. And here we look at the need for an agency for advocacy for nurses. Answers has been working for 20 years on advocacy for healthcare professionals as one group, but also other groups, that is women, adolescents, and women leaders, women activists and women leaders. Advocacy in these areas has given us a very clear conceptual design for what advocacy means and how it will be done at different levels. The first issue was for us to look at advocacy as a tool for empowerment. Can I have the next slide, please, Christa? This is what the track of Answers means. We've been doing training research like most technical organizations, but advocacy and capacity building has been at the mainstream of our work. Here we see advocacy as an organization without power, position, or profit, advocating on behalf of others. And among all the groups that we identified as requiring advocacy are women care providers. The DICE that is the traditional birth attendants, the ANMs, the PHNs, the nurses and midwives. So this is where we come in, doing advocacy for these groups. And nurses have been one of the special groups for whom we have been advocating over the years. And that is where this work and these narratives come in. The next slide, please, Christa. Now I come to actually sharing with you very few preliminary points, not for quoting because they are still work in progress. And that is to discuss the determinants of migration of Indian nurses to the USA. This is based on my last 2 months of work, of interviews, and the process of narration which is going on. Maybe the narration, I call this as a collective narration, a collective reflection and narration, where a group of 12 to 15 senior nurses migrating to the USA sit, reflect collectively, and tell their stories. So that's the type of short biography that I'm writing. But through these and through the 120 or so interviews which have been done so far, we come to first, the most important is the determinant is the economic factor, but there is a slight difference. This was the key factor in the 1970s. It is still a key factor, but in the 1970s, it was upliftment of the family, the whole family financially. And this played a role more with migrant nurses who went with a diploma in nursing. And the migration took place through churches, mission hospitals, relatives, friends, and priests. So there is a slight difference in the process and the need between the 1970s migrations and the migrations in the 1990s and after 2000. And there is a difference in socio-demographic profiles also. These nurses belong to large families. Usually the siblings, the family size was 6 to 8. And the nurse who migrated was usually the oldest child or the oldest sister in the family. They belong to middle class and lower middle class, with the parents partially educated, mainly in smaller jobs or in farming jobs. After going to the USA, most of these people, who many of them are now, have been in the USA 40 to 50 years, they helped to sponsor first their spouses, their siblings, and their families. So the huge network, family network within the USA of these early migrant nurses. Not only helping and building a network, a financial, social network in the USA, they have built houses, acquired property, and helped many ways to the families in India. So this is kind of a picture that we have of the early migrant nurses to the USA. Can I have the next slide, please? Okay, the second category, and this is, as I said, just a preliminary finding, is the psychosocial denial factor that I call. And this is, again, the older group, the group which went in the 70s, late 60s and 70s. This is the group which was a slightly more educated. They entered a college of nursing in a prestigious university with the misconception that this was equal to medical practice or medical education. And once they started their clinical practice, they realized that this is nothing but caring work, which in India is associated with menial work or work that does not have much dignity. It is and has a lot of stigma, comes in the way of social development. And these are middle and upper middle class families with family members and siblings who have been highly educated and are professionals and have been doing well in the social political field within the village and within the local area. Some of them even in state politics. Many of these migrants went through, as I said, a 4-year degree course, but they did not like being a nurse after completing. They had tried for admission to medical colleges and were studying other courses of study before they entered into nursing, and they could not afford, or their score was slightly lower than those who, the cutoff point for the medical colleges. Many of these earlier nurses from prestigious universities in India entered into medical colleges after going to the USA, in the Caribbean, in Mexico and the UK, and are now practicing in the USA. So this is the second category of the senior migrating nurses, Indian nurses that I found. Can I have the next slide, please? So this, we come now to the later migrant nurses who are late 90s, 92, 96, 99, and the whole group after 2000, 2003 to 2006. This group went for a different reason, still there's economic reason, of course, but more for better prospects and to join the American dream of doing well for themselves and their families, and especially their children. Most of these are also second country immigrants. They have been in the Gulf for 5 years to 10 years. Some of them have been for even 12 years in the Gulf, either in the Sultanate of Oman, Kuwait, Saudi, and then they have seen better prospects. They have earned a good income. Some of them, in fact, brought a lot of money that they earned in the Gulf to the US. They were recruited because of the huge number of recruiting agencies which were scouting around in the Gulf countries, especially in Dubai, trying to identify nurses for the US and other countries. So they had better, the whole category, socio-demographic and professional category is slightly different. They had better access to facilities. The internet was there already. They were very tech savvy. They had better amenities at work in the Gulf countries, and therefore they had increased aspirations. And many of them came after marriage, along with their spouses, with little children, and they had a family visa. They went through the tests, they had coaching centers. So this is the second category, which is slightly different from the early migrating nurses. Next slide, please. So the third category, and here I'm just talking conceptually because this is only in the beginning stages of my work. Nurses with higher education who wanted to apply their knowledge and skills and found the Indian professional system, atmosphere, not allowing them to have autonomous or independent practice. This goal for using their knowledge and skills in a better work atmosphere for better dignity became one of the important criteria for migration, not so much the money or the helping the families. Many of them, again, have done graduation and post-graduation in India. They had coaching centers, they went as groups, they helped each other, and this group I see is the one which seems to be most satisfied today while working in the USA. These, as I said, Christa, these are only preliminary thoughts that I have, and hoping within the next 6 months, we'll have this ready, and we are looking for more inputs, because it is all voluntary input that migrating nurses are providing, because it's not a confidential inquiry, it is open domain knowledge sharing. So I'm still looking for, December 15th is my last cutoff point for taking inputs into the work, and then we'll be starting to write. So I'll stop here and hope I have thrown some light on what's happening and how the situation is at present. Thank you.
Thank you very much, Prakasamma, for this first insights, in particular in the motivation and the root causes for out-migration of nurses, in your case to the USA. And I'm looking around and I'm wondering whether Professor Rajan did join us, but I don't see him.
Yes, I'm joined.
Welcome. We are very happy that you joined. Professor Irudaya Rajan is chair of the International Institute of Migration and Development, India, and also chair of the World Bank KNOMAD Working Group on International Migration and Urbanization. He is editor of 2 Routledge series, India Migration Report, already since 2010, and South Asia Migration Report since 2017, and founding editor-in-chief, Migration and Development. And I'm extremely happy that he joined us because He is such a prominent voice in migration studies that we are very happy to have you with us. The floor is yours, please.
Thank you. Thank you so much, Christa, for the kind words, and also pleased to, ask me to speak in this meeting by Sanghamitra, who asked me if I can join this program. I was stuck in Chennai. I just came to Chennai, then heavy rain now. So I was delayed by a few minutes. And thank you very much for the invitation again. And I would like today to speak something which normally I don't speak, because I normally speak on something on nurse migration. Today I thought I will speak mostly on the barriers. What are the barriers for female migration, especially the health workers? I think that's what I'm going to do in the next 10 to 12 minutes. I'm not going to speak more. And then, of course, I'll be available for the discussion. This especially the health worker migration. I want to start with the barriers in education, train the nurses so that they have to leave from state to state, and maybe even outside the country to study. For example, many people we have seen during Russian war, there are many people from India were studying medical profession, education in other countries. So I think we should look at the barriers for women to study what is called this education on what is called the health level education or health professionals education. And added to that, there is another big infrastructure, or what I call them, very high fees for the studying nursing in India, for example. Some people talk to me, they say 300,000 rupees or 500,000 rupees they have to spend to study the nursing, for example, just nursing. So you can imagine, not only you have barriers for studying institution, there's also barrier for paying the huge fees which people are collecting. And then some of them are not able to pay the fees back, or when they take a loan, they are not able to pay the fees back. They have to migrate. They are not even ready to work in their own country because they have paid so much money. So much money, they are ready to work even in the war zones, in countries where the India says you don't go, still they are there, nurses. I think this is something, the initial period, there is a lot of issues on the barriers of paying the very, very high cost. And next to you have the barrier is what is called the job market. I think there is a job market is also another barrier. It is not like the doctors, nurses are, sometimes they were discussed and they were not paid wages. Probably they are getting more wages than what they get in India, but there is a wage discrimination. There is a job discrimination. I think there is a big, what is called the job market is another big issue which is happening for the nurses, because there are only some of the agencies are not only allowed to recruit nurses. The fourth barrier now in India is the passports. We have barriers in passport because earlier the nurses can go, but now the government is telling they have to get through the what is called the clearance from the government. So, and they only designated very few institutions to recruit nurses. That leads to nurses going through underground, going through many routes, going as domestic worker visa, then getting into nursing. There are a lot of processes happening because there are barriers for them, free mobility in India. I think there's a barrier for them to migrate because they are put in some new categories in India and they are not able to migrate as free as they can. And then you have the barriers in what I call them in the destination countries. Some of you probably might have read recently, there is a nurse called Nimisa. Nimisa was, sentenced to death in Yemen. She's a nurse. She's from Kerala. She's a nurse and she went there, but she wanted to start something on her own. But then there is a barrier for her to start working. So she needs a sponsor, and the sponsor is a Yemen national, and he started exploiting. And then she wanted to leave the country, but then passport was with her, with that man. So she thought, I will do something to get the passport and run back to Kerala. But then she put him some what is called injection to keep him, what is called some type of dosiness. But she has given more medicine that Yemeni national died there. Now, That means she wanted to do something, but she's not able to do. There is a barrier for her to start an institution, to run a small medical clinic. They are not allowed. Then there is a sponsor system is coming up. Then, so you have the problems before they leave in the countries of origin, like India. Then they have problem in the countries of destinations. Some of you probably remember India had a big strike in Kerala for nurses. Nurses went on strike. So I was asking one time, why your people are striking? They said, we are paid only 4,000 rupees. We don't get even minimum wages after spending so much money. And earlier, we worked for 1 or 2 years in Kerala, then we'll go to Gulf. Now Gulf is not picking up. So we have to be in India. So we have to get married. We have to live life. We cannot live with 4,000 rupees salary. They went on a strike. And the government said, we should have minimum salary. Some amount was fixed. Because the migration is coming down in many countries. Of course, thanks to COVID, there is a new demand for nurse migration. Then barriers to return. We have seen during COVID-19 how many nurses were allowed to return, because in the country, they were what is called the main person taking care of the health of the other country nationals. They were in the hospital, they were there, and some nurses even died there in many countries, including in our country. So I think they have barriers from education infrastructure, barriers in recruitment infrastructure. There are many agencies in India, they don't want to recruit nurses. Why? Why you are not recruiting nurses? I think these are the questions we have to ask. And finally, what are the policies? Some returned migrants want to come. Some of the nurses work in the Gulf. They don't want to go to America. They don't want to go to London. They want to spend 10 years, come back, construct a small house in their own village in Trivalla or someplace. Then what are the facilities you have for them to rehabilitate or readjust in the countries of origin? These are the questions I want we should discuss further after my presentation. That's what I want to say right now. Thank you, Christa, for giving me the opportunity. Thank you very much.
Thank you very much, Professor Rajan, for introducing barriers to us. We are talking a lot about driving forces, about push and pull, but barriers are, of course, as well, very important factors in this process of migration. So this is a very important addition to our mapping of processes, of power relations, and whatever is going on in migration. Now I would like to turn to our third speaker, who is as well very, very prominent for the literature on migration of Indian nurses. That is Professor Margaret Walton-Roberts. Margaret Walton-Roberts is a professor in the Geography and Environmental Studies Department at Wilfrid Laurier University and affiliated to the Balsillie School of International Affairs, Waterloo, Ontario. She has published widely in issues related to gender and migration and global health professional migration. Her most recent book is Global Health Worker Migration, Problems and Solutions, published with Cambridge University Press. Margaret, you have a PowerPoint. Can you share your screen? Yes.
You can put on people. So thank you so much for this opportunity. I have very much enjoyed listening to the discussion and the presentations thus far from Prakasamma and Professor Irudaya Rajan. Very interesting. I'm very grateful for the invitation, and I hope that I can get through this under the 15 minutes. I want to talk about thinking about fair migration, and my approach is a little bit more global, contrasting global nurse migration pathways. What I want to do is sort of take us through. I'm a geographer, so I like to kind of play with scale and location. So I'm going to try to look at this from a scale perspective as well. Starting at a kind of a global scale and then moving down to look especially at India, Canada. And And so hopefully we can go on this journey together. I'm going to talk about the research I've been conducting on a SHIRK-funded research project that Professor Rajan is part of, and it's looking at global nurse migration pathways. This work is internationally comparative. It looks at 3 country pairs, understanding different migration pathways between those countries. So looking at India, Canada. In our case, we're looking at kind of 2-step student migration to work visa. Vietnam, Germany, looking at the triple win model that Professor Christa mentioned earlier. And Philippines, Singapore, which is primarily a temporary migration regime. So we are towards the end of our process. We're about to begin an online survey for the grant. It's actually a little longer, 2025 now, with the COVID delays. We have done some key informant interviews, data mining key informant interviews, and we'll begin an online survey. And we've done some story mapping as well. Our kind of data mining, looking at these 3 countries, has really tried to understand how they all came to the position to engage with the idea of the kind of the export of nurses more systematically. And the Philippines is, of course, the leader in this field. But India, as Prakasamma mentioned, has become very much a player in this global field. And then also Vietnam is an interesting example. Vietnam has a sort of a triple win agreement, the kind of triple win agreement with Germany, but it hasn't really been as successful. And it's more an opportunity for the migration of what's interesting in the Vietnam-Germany case is that there's already the well-established link since before unification of Germany, and so there's some very interesting kind of migrant networks happening there. So we're still sort of examining that very interesting example. So we've been looking at these 3 pathways and the different kinds of migrant steps involved for nurses who are moving between these countries. In thinking about the global migration of nurses and health professionals more broadly, one of the interesting things is always like, where can we find our data? How do we know what's actually happening on the ground? And one of the interesting places to look is the World Health Organization's national health workforce data. This is a sort of a global platform that the WHO has created, which is trying to sort of standardize information on health workforce in support of what we could call global health solidarity. So it's the idea of we want to reach universal health care, and we need to know what's happening in different countries. It's also links in with, as Christa mentioned at the beginning of the seminar, the importance of the WHO code on the international recruitment of health professionals, and that code is in the spirit of countries being aware of the fact that whatever they do should not encroach upon the ability of the sending countries to achieve universal health coverage or healthcare themselves. So there is this overarching kind of global governance framework is about trying to understand this notion of global health solidarity. And I think that's an interesting thing to keep in mind as we discuss these issues. So there's lots of interesting data that can be identified through these platforms. And just to say, a note about the mobility of health professionals internationally, it's very interesting to examine the experiences of numerous countries, because of course there's a lot of small island states and small countries that really don't have the capacity to train all of the health professionals they need. So there is a lot of mobility of health professionals between countries in securing their education. And so just generally understanding that migration and mobility dimension is a very rich one, and these sorts of databases can help us explore it. If we look to a more specific OECD data grouping, what we have here is this club of mostly rich countries. And that data that is gathered by the OECD is very interesting for showing us how many of the doctors and nurses in those countries are foreign trained. So this really gives us a barometer of what's been going on in terms of those experiences. And we can see some of the leading countries to which foreign trained health professionals are going. Of course, the US, Canada, Germany, Australia, these are always some of the main recipients of this internationally trained health labour. In Canada, we do have national data. It's gathered by the Canadian Health Informatics and Statistics Canada. They collect this standardized health workforce data. It does give us some sense of what's kind of going on in terms of internationally trained health professionals, but there are certainly some lapses in that data. It's sort of difficult to get a full picture of what's going on, as I'll discuss. And then just to follow up on that point about the OEC data, what we see is that the distribution of foreign-born doctors and nurses are heavily concentrated in certain countries. So there are 5 destination countries that concentrate more than 75% of all the migrant health workers across the OECD. So as I mentioned, the US, Germany, the United Kingdom, Australia, Canada are the sort of top countries that are home to a number of the internationally trained health professionals. And what this tells us immediately is that those countries are not doing enough to boost their own domestic training and improve the working conditions for health professionals in their own sectors. And also when we drill down to the experiences of nurses in those countries, we want to pay attention to whether there's evidence of what we call brain waste, or the deep underutilization of the skills of migrant healthcare workers. Now, if I were to, so I'll take a moment now to just talk in more detail about Canada. Canada's Medicare system has long benefited from the contributions of internationally educated health professionals. There's a very interesting book that came out a couple of years ago called Foreign Practices, and it really is a very fascinating history of Canadian Medicare, but embedded with that analysis of the emergence and development of the Canadian Medicare system is the reality that from the very beginning it was highly dependent on the integration of foreign trained health professionals. But interestingly enough, and as you read this book, sometimes it just feels like deja vu. Even in the 1950s and 60s, there were concerns about certain issues that are still a concern today. So it's about the problem of foreign credential non-recognition. This is a very systematic barrier that's been present in Canada for some time. And it's sort of fascinating to read the history of this, that it still seems as if we haven't really made that much advancing with regards to the very tricky system here of professional recognition of credentials. Of course, the COVID-19 pandemic, as everybody knows, has really elevated this problem throughout. And just to drill down again, when we look at Canada more intently, we see that the incorporation of internationally trained health professionals is very diverse across all of the cadres of health professionals. So this data on the graph gives you the location of the training of occupational therapists, pharmacists, physicians, physiotherapists, and nurses. And you can see that the biggest dominance of internationally trained professionals is in the field of pharmacy, another area where India is certainly taking a lead, and then physicians, and then physiotherapists, and then nurses. There are multiple immigration pathways into Canada, and this results in a number of data challenges when actually trying to map, who's coming into Canada, what are their skills, are their skills being fully utilized? And there are systematic barriers following on, as Rajan has just mentioned, in terms of recognition of foreign credentials. So the process is lengthy, it is complex, and it's also costly. And just this image here comes from an article that I wrote with Raphael Haroun. We published this in Human Resources for Health. And this is just a graphic to illustrate the multiple migration pathways that, in this case, internationally educated nurses or IENs could engage in to enter Canada. So increasingly now in Canada, we're seeing massive numbers of temporary workers, and that includes international students, and I'll talk more about them in a moment, as well as permanent immigrants, and they can come in as family class or sponsored. And for each different pathway that people can enter the country, there are different ways they can find their way into the Canadian health workforce, be it regulated or unregulated, and also fall into other sectors of work. And so this is just to illustrate the complexity of the different pathways. And of course, there are various barriers to each of those groups as they move towards seeking employment in the Canadian health workforce. Just to detail in a little more what the challenges are for internationally educated nurses. I am based in Ontario. Ontario is one of the biggest recipients of immigrants to Canada. The College of Nurses of Ontario is one of the larger and more of a leader in terms of the regulatory agencies, but across Canada, the regulatory agencies do work together in the field of nursing. This graphic comes from the CNO website to tell internationally educated nurses what the registration requirements are. There is an 8-step process, and of course, each of those steps requires you have to pay fees to secure assessment of your documents. So you have to provide your educational documents. They have to be valid. They have to be translated. And again, if you can imagine, if you've come as a refugee, leaving civil sites of conflict, it's difficult to have been able to get your hands on your documents. You need to prove evidence of practice. The safe practice window is 3 years, which is not that long, considering all of the things that could go on during that period. Registration, you have to take different exams. You have to prove the skills and competencies. This all requires testing. The timing is important, and again, it costs money. There's also language testing, and timing is involved there because the tests are only valid for so long. This costs money. You also need to have authorization to work in Canada. That could also includes those who are temporary or permanent, and this all costs money. For our work looking at the India-Canada pathway that we have selected, what we're interested in is the emergence of a system of migration that we call 2-step. It's actually more kind of like a 3-step. But what we've found is that nurses who have been trained in India have been coming to Canada very soon after their graduation and actually enrolling in college programs. So they come as students, they enter programs that are postgraduate programs. This is certainly mobilized by education or employment brokers who are active in India, but also in Canada. The college sector does have its own international recruitment. They're very interested in building revenue from international students. This has been something that Canada has seen really explode over the last 10 years or more. Step 1 is the individual gets a student visa. It could be self-financed, it could be savings, it could be loans. And so this goes to the issue of debt that Rajan mentioned before. Usually what happens is they enter a program, and at the same time, in a parallel process, they submit all of their applications to be evaluated by the regulatory college. In our case, we're looking at Ontario, but it could be any one of the provinces in Canada. So as they're undertaking their studies, their documents are being evaluated by the regulator. After they finish their program of study, they apply to get a postgraduate work visa. This allows them to work. And hopefully by that time, if they've done a study that is, if they've been in college for 1 or 2 years, hopefully by then they've completed all of the assessment and licensing processes, so they can actually find work as a registered or nurse or registered practical nurse. They can work for some time in that capacity, and then they apply for permanent residence. And this is the sort of 2-step or the 3-step process. It looks very straightforward and streamlined here, but it can be a very time-sensitive process that causes all kinds of stress for the applicant. What happens then to internationally educated nurses once they've actually gone through that whole process and actually secured employment and become permanent residents? So, or even just secured employment, where are they working across Canada, across Ontario? So we requested, and again, this comes from the work I did with Raphael Haroun, we requested a special data set to look into this. And our data indicated that there's an increase in internationally educated nurses as registered practical nurses as compared to nurse practitioners or registered nurses. This is important because registered practical nurses are a sort of slightly lesser cadre. Their scope of practice is more limited. There are employment opportunities, but their autonomy is more constrained. But it is an opportunity for them to find work. And so certainly we've seen an increase in the number of IENs who are registered practical nurses. And that over the period of assessment with the data that we looked at between 2011 and 2020, the number of internationally educated nurses who are operating as registered practical nurses increased by 255%. And that contrasts to the smaller 3% increase for those who are nurse practitioners or registered nurses. When we look down at the level of what's called local health integrated networks, the data emphatically points towards notable growth in internationally educated nurses as registered practical nurses across Ontario. And what we found was interesting is this is especially evident in communities that have a moderate to low population density. So this is evidence of those IENs actually moving out of the larger cities and finding employment in smaller communities in Ontario, further away from the large metropolitan centre, Ontario, that being Ontario. And so we think this is kind of interesting. We think it reflects some issues in terms of how the Philippines nursing assessments were looked at. But we need to drill down a little more and see how this affects Indian trained nurses. But what we can say is there is this distribution of nurses, internationally educated nurses across the province, like away from the larger cities, seeking opportunities to work, often working in places like long-term care facilities, community health, nursing homes. And so on the table 6 there, you can see internationally educated nurses. Where are they working across the province? You can see a greater representation in nursing homes, long-term care facilities, both in 2011 and 2020. And so that is the sector that we're seeing that kind of concentration of internationally educated nurses working.
Margaret, can you?
So just to wrap up, I'll just wrap up now.
Slowly.
Yeah, so this is the final slide. I just want to say that what you can see in what I've tried to demonstrate here is the different pathways that internationally educated nurses are taking into Canada. Then their experiences in the workplace are really concentrated in the lower cadre of a registered practical nurse. They're working in long-term care homes, so more working with the elderly. And then going back again to the global, what can we say about this from a global perspective? And I think this builds on a lot of the comments made by others. Nursing is certainly a feminized profession. We're witnessing the global migration of care workers, helping countries deal with what's the crisis of care, especially with an aging population. We do have some global governance frames that look at this from the issue of health solidarity and promote migration rights, which we need to pay more attention to when we actually look at what happens to them in the receiving countries, but also in the sending countries in terms of working conditions. And we need to consider how sustainable and fair internationally educated health professional pathways are. And so we've looked at this in the case of nursing. So thank you.
Thank you very much, Professor Margaret, for this very comprehensive picture overview you gave us. And what is very clear, what a complex process migration is. And I thank you for raising the question of brain waste and showing us where the skills of foreign trained nurses used, for example, in homes for the elderly, in lower cadres. And it's the same I heard in interviews with Indian nurses in Germany, that they feel that they have a very good education, but their skills are underutilized and their knowledge is underutilized. So this is a very important aspect we have to add. And you showed us that migration is a multi-stepped process. This is time and cost intensive. This point of costs is coming up again and again, as Rajan mentioned already, the high fees and the debt for the students and their parents. So thank you very much again, and I hand over to Professor Ramila Bisht. Ramila Bisht is a professor at the Center of Social Medicine and Community Health, JNU. Her research interests comprise issues related to health policy and reforms in India, comparative health systems and policies, urbanization, environment and health inequalities, and the gendered, social, and cultural determinants of women's health. Actually, Professor Ramila was planning to present her study together with a colleague from London, but the colleague Sibille Merz from London is down with COVID. So I have to welcome Professor Ramila and wonder whether you can share your screen.
Is this?
Yes.
You see the screen? Okay. Yes. Thank you so much, Christa, and thank you for inviting us to share findings of our study. Now, in this paper, we're looking at trends in commercialization of training and how specific labor market demands in Global North, and in our case, the UK, are driving this. So in a way, I'm moving from, what our presenters before me have been presenting. I'm now going to start focusing on the migration industry, to start looking at the migration intermediaries, the brokers, the commercial agencies, all of which that are involved in this process. And just one second. Make very clear that this is part of a very large project that we did, where we were looking at commercialization and transnationalism in the provisioning of services in the social sector. And we were not really emphasizing on migration, but labor source processing was one of the important components of this. This study was done as an ESRC funded project, and it had case studies of India and China. And the fieldwork for this happened between March 22 to January, and then again, January, March 2023. And we did about 27 expert interviews with migration brokers, policymakers, healthcare providers in Kochi, as well as in New Delhi. And we also looked at a lot of secondary material and online resources. Some interviews were also done in UK. And it's a small slice of it is what I'm presenting today. Now, I mean, this is a background that I really don't need to emphasize much. We are pretty much clear that there is a very, very long history of migration of Indian healthcare workers to UK, very close colonial ties that UK has with India. And in earlier times, it was predominantly doctors who were coming to UK, and increasingly now it's the nurses and the allied health professionals. And according to the NMC, which is the Nursing and Midwifery Council data, almost 48,000 Indian nurses are registered with them. And there is also a huge vacancy, almost a glaring vacancy for nursing positions in UK. About 40,000 vacancies are there. And the government has increasingly sourced international nurses to fill these gaps. As a key policy instrument for this, there is a policy document which is called 50,000 Nurses Program. And it aims to increase the number of registered nurses to about 50,000 by March next year. And about 51 to 57,000 of these nurses should come from international recruitment alone. Now, this is the second highest source of recruitment for them after domestic training. And we also have an international policy context for this, where we are witnessing a bilateral efforts between the two countries to ease the movement of health workers. And this is specifically centering around recognition of degrees and specialized training, which have been, we've been hearing, one of the main barriers to movement. So this program, this bilateral framework was signed in 2022 between the two countries, and it was an important initiative to train Indian nurses according to the UK and NHS standards. And these included, the training that they were conceiving included subjects that were probably not so strongly mentioned or were missing in the Indian curricula. Therefore, there were, things like emergency and trauma care, mental health, neonatal intensive care, palliative. These kinds of large-scale training were going to be planned between the two countries. Of course, our project ended in May this year, so we've not been able to observe any government-initiated efforts on the ground, so I can't say what has happened with it. This is the kind of policy context within which the training in this field is taking place. The state of nursing in India is also something that I don't really need to emphasize. We've heard from eminent speakers about, how a large number of nurses are working outside India, and there are a whole lot of, push factors for it, and they also have a lot of precarious working conditions. And a large number of these nurses are, moving from the south, though, of course, it's changing, and probably we'll have the next speaker telling us about new areas from which you see nurses are moving. But what I particularly wanted to emphasize now in this presentation was that, we know that there is a growing in terms of numbers and evolving in a very complex migration industry in India, with many state and non-state, domestic and international actors playing significant role in it. These migration companies or migration brokers or commercial agencies, rather than just facilitating travel, they shape a lot of very important things. They shape the nursing curricula, they provide broker on-the-job training, they offer a range of training services. And if you look at the advertisements and billboards of these agencies, they tend to mobilize a dream of a global career for these aspiring nurses. But once you start looking at it carefully, you realize that the training that they impart towards this dream is far from globally relevant. It is often, tailored towards protection of access of nursing jobs to individual countries. So what is actually produced is not simply a global nurse. What is actually really produced from this training, a global customized nurse who is ready to meet specific shortages in certain countries, or who's capable of, smoothly adjusting to work settings of those countries. And in this presentation, I will take you through 3 types of such customized skill training services that we found when we did our interviews with these intermediaries. The first example that I wanted to share with you was of training for specific licensing exams, including the training for, an exam called Objective Structured Clinical Examination, or the OSCE. So a range of Indian recruitment agencies offer these training specifically for these exams. And OSCE is a very, very important exam because it's a clinical competency test. And nurses who wish to work in UK but have been trained outside have to get registered with the NMC, or the Nursing and Midwifery Council of the UK. This, in order to get registered there, it is mandatory that they clear this OSCE exam. And we found that there were commercial agencies, both in UK and India, who had set up special training modules for this. And they were trying to cover things which were not being there, which were not being adequately taught in the nursing curricula in India. And they had even set up special centers for it. For instance, one of these agencies that we spoke to was, that agency had set up a training program for mental health nursing. So there was not just a training program, but he had set up practical examination modules. And this the agency said they felt the need to do because there was a high demand for trained mental health nurses in the NHS at that point of time. And he was not able to have nurses in India. So this necessitated that he develop these modules and train them, so enabling them to pass the mental health modules of the OSCE. And at the time of our interview, about 120 such nurses who had been trained by them and had cleared the OSCE were ready to be placed with the NHS. Another kind of an agent that we found, an India-based agent that we found very interesting, was somebody who set up a boot camp style model, where the agency was offering OSCE training through a residential program for immigrant nurses in UK. Very, very shrewdly, they used the opportunity which was created by the COVID-19 pandemic of mandatory 10-day quarantine in UK. They specifically bought property for this, and they housed the nurses in that, and they organized the training during this period. Now, we must keep in mind that most of the cost of training is covered by the NHS Trust because UK adheres to the WHO Global Code. But anything that qualifies as additional has to be borne by the nurses. And given the commercial nature of these services, these courses are therefore, offered at very, very significantly high costs. And therefore, they are rather exploitative of nurses who generally come from non-affluent social backgrounds. And further to this, there is a clause in the nurses' contract. I mean, these contracts are for a period of 2 to 3 years. And if the nurses breach this contract, they have to repay the trust. And this, of course, varies from one trust to the other, but sometimes it can go up to about 75% of the cost if they leave in the first year itself, which nearly is about £9,000. And naturally, this puts a lot of burden on the nurses. The second example that I wanted to share with you was of simulation-based training for a piece of equipment or technology that was being provided to the nurses. There exists a bilateral agreement between the UK providers and Indian agencies for specialty training in specific technologies. And these agreements are usually signed between individual hospitals in the NHS with the private agencies to meet the recruitment needs for nurses in the specific technologies. So a lot of this training is done in India to cut the cost. The Indian agencies procure equipments which are used, say, in UK, and then train the nurses here on that. And this brings in a lot of saving for them. For instance, one Gurgaon-based agency had bought ventilators which were being used in an NHS-based hospital in ICU, NHS-based hospital's ICU, and was training these nurses on the use of that ventilator. There is a Chandigarh-based training called INSCOL. Now, this company has been for a very, very long period of time been using these simulation techniques for customized training. Of course, much of their focus is on sending nurses to Canada, but we do find that agencies use this kind of training. They use these, they do provide these kinds of training to equip the nurses and make them meet with the needs and standards of standards demanded by UK-based agencies. The last example that I wanted to share with you was the soft skill training, which is also on offer in the nursing migration industry. Now, nurses are trained in different clinical cultures and value systems to meet specific national expectations. Now, in our case, we found that the training that was being provided was aiming to mold these nurses according to the approach, norms, values, and practices of what was perceived to constitute the healthcare cultural framework of the NHS. And this soft skill training was set to make the nurse much more prepared to meet any possible cultural challenges that arise out of differing clinical practices or cultural perceptions and behaviors, say around issues like patient data confidentiality or consent taking in emergency care. The Indian nurses were described as being rather differential, or they came from a culture of pleasing, making them very reluctant to raise concerns. And some of the UK respondents argued that this could become a further ground for errors, ultimately compromising patient safety. And another Indian healthcare broker explained to us that many nurses run into trouble during the first 6 months because of these kinds of differentials that they have. And this training we found was being provided by both NHS providers and the Indian agents. NHS had, some of the trusts had in-house teams for it, but many of them also outsourced it to other subsidiaries. And these programs ranged from very brief introduction sessions to month-long induction packages. And there was one agency which also had plans for setting up a finishing school for nurses and other allied health professionals towards, the goal of cultural production of global health workers. So what we found was that—
Can you please come to the end?
Yes, just a second. We found that they're not focusing on any verifiable skills, but they are targeting traits which are much more subjective. So in conclusion, rather than producing global workers, nurse migration companies produce actually customized or bespoke workers. And what I wanted to just emphasize and conclude was that knowledge skills are not selected on needs-based approach, but are governed by these international market opportunities. And we also found that this additional training that I said adds significant cost to the nurses. These payback clauses that we have in the NHS really leave them very indebted. And overall, there is this kind of approach creates a precarity for nurses, because there is a fluctuating demand for different things in this volatile job market. So nurses may be trained in one thing, and if they don't make their journey to that country within a given time, they may find that what they're trained in is quite useless. And lastly, and most importantly, I just wanted to raise this point that this market reform in nursing education is carried out on the garb of enhancing skills, but are really in the interests of market profitability. And these agencies are largely private agencies, and they escape state regulations. So sometimes they can just get by even with providing below par training. Thank you, Christa.
Okay, thank you very much, Ramila. This was an excellent, gave us an excellent insight into the work and the objectives of intermediaries and the growing number of commercial agencies which is coming up. And it's really a new, very clear perspective that it's not about the training, it's not about the construction of a global nurse, but it's about a global customized nurse with a training for specialized niches and specific clinical culture, and that it is not needs-based, but market-based, meaning profit-based. So thank you very much for this insights in the market reform in nursing education. Yeah, last but not least, our next presenter is Dr. Shashi Mawar. She is assistant professor at the AIIMS College of Nursing in New Delhi, and she works as a researcher and teacher. Her area of interest is integrated care for the elderly and improved quality of life. And I think she takes us now more to the northeast of India. Ramila, can you please close your screen?
Good evening, everyone. Thank you, Christy.
Yes, floor is yours.
Am I audible?
Yes.
Okay. So first of all, thank you for the opportunity to be talking amongst you all. I haven't done much of work in migration, but I have, since I'm working in a nursing college, and I come across checking the transcripts, and I know that where do our students are, which countries they are going, and what are the reasons for which they are leaving. So since I'm asked to talk more about the northeast region of India, I will just take you to the geographical background of northeast India. Basically, northeast India comprises of 8 sister states. They are Assam, Arunachal Pradesh, Meghalaya, Nagaland, Manipur, Mizoram, Tripura, as well as Sikkim. So in these states, there are certain problems which are happening on day-to-day basis. And because of these certain problems, these are the reasons which the local people face, and they find themselves to be moving out from these places. So one of the important reasons is there is a poor transportation as well as communication in that area. There are ethnic conflicts as well as insurgency in that area. There is illegal taxing as well as extortion and even drug trafficking. So most of the people who want to have some kind of stability in their life, in their families, they intend to move outside the state. So it is not only migration within India to other states, but it is a global migration also by the northeast nurses. And these are not the reasons for migration only for the nurses, but it is for the major workforce from these states. So if we look at the data somewhere back in 2015, it has been shown that almost 52.7% of the migrants, they have migrated within the country itself. And the most common states to which within India when they migrate, those are basically Uttar Pradesh, Delhi, Maharashtra, Karnataka, and Bihar. And in earlier times, it was noticed that the migration used to take place only from South India. But now, Northeast people, they are more commonly migrating to South Indian states because there has been a lack of workforce in the South Indian states in India nowadays. So the population which has been migrating to Northeast states have declined after 2011. And the major reasons for the nurses or the other workforce, including the health workforce itself, those include the work as well as employment, because in Northeast, there are not much opportunities of employment on their own. Then business, people want to go out for business. Then education, and there are not many good educational institutes also specifically for nursing. So these people who want to be educated in the nursing background or in the nursing field, they migrate from northeast states to the other parts of the country. And even WHO status has said that 1 out of every 8 nurse who has been educated in a particular college in a particular state is migrating, is not working in that particular state itself. So it has been observed that there is a lot of interstate migration, and it is mainly female dominated. So this was the these are the reasons for northeast state migration. Now coming to the Indian scenario regarding the migration of nurses, it has been seen that India is a major supplier of migrant nurses, not only to specific countries, but globally, India is a major supplier. So it has also been seen that most of the initially, nurses used to migrate only to the Gulf countries, but now the trend has changed, and nurses are migrating to UK, Philippines, and Germany. And in the initial talk also, Professor Ramila Bisht also has mentioned that there are several companies which are coming up, and these people, they are training the nurses on producing specific customized workforce in nursing. So these people, they attract the nurses right from there. Even it is not only they do the graduation here, but even before the graduation is completed, they try to attract the Indian nurses, and they train them for the language, they train them regarding the environment in which they are working. Recently, only during my conference, I have come across 3 companies which are working quite hard on taking these nurses out. Few of the, though these are private agencies, but I'll name them. It is one of them is regarding migration to Germany, and these people, they start right from the language, they teach them the culture, and since their population trend is changing, so they are more into elderly care. And since I am also involved into elderly care, they had approached me also if I know about any places where nurses are already trained in elderly care in Indian setup, so they can train them better, and only for them the training will be required only for the Germany language. So this was an ITC company, that is International Trading Corporation, which is for the Overseas Recruitment Corporation, and they are working on taking people to Germany. Another is FBNPC, that is Future Building Nursing Preparation Center. This is again a Canadian based company, and most of these private companies, they are working on Canadian based companies. And in the latest trends, it has been seen that Indian nurses, they move to Australia, UK, then Germany, and these places, Philippines, etc. But earlier nurses were moving to Gulf countries. Nowadays, the trend is decreased, and only the South Indian nurses or the South Indian state nurses, they are moving. But Northeast nurses, they are moving across the globe to any place wherever they get an opportunity. So if you look at some of the pull and the push factors among these people, among these group of people who are interested in going abroad, the push factors include the low salaries, the working condition in India, though the trend has changed now, and the working conditions specifically in the government setup, they have improved quite a lot. And the salaries are also improved, but still in the private sector, the condition is very bad. And therefore, nurses who are not able to get their jobs in the government setup, they are moving outside. Then heavy workload is there, understaffing, because most of the people, they are going to other countries. So here they are usually, like, we are lacking, we are having a shortage of nurses. Then lack of resources and proper infrastructure, poorly defined job roles. That is most of the people, specifically those people who are highly educated and those who actually want to do good in their profession, are they want to do some independent practices, which is not available in India. So in search of independent practices and autonomous working environment where we can take our own decisions, that is not available. So intelligent people, they move as nurse practitioners to US. Then limited promotion opportunities are here. We don't have any protocols, and we just have to follow the instructions which are there. So so many people don't like to work in these conditions. Then less opportunities for higher education. Even if education is there, nowadays a lot many colleges are there which are providing master's program as well as PhD programs, but then the job opportunities are lacking after higher education. So, and then there are restrictive administrative regulations also. So because of which people are not able to move. Then the pull factors include the lucrative salary packages outside. There's less workload, and the person can decide that which shift I want to work. The person is able to also do independent practice outside, which is not available in India. Then employee friendly policies are there. Then they have their own, they can have their own working hours. They can select those working hours depending upon their family needs. So these are some of the factors which attract them to go outside. Then obviously a respectful treatment, opportunities for professional growth and skill development which are there, and opportunity to work with high technology. So but in India also nowadays in many setups high technology is available, but not in all setups. But abroad they will get high technology opportunities, practice more. Then better career opportunities, and obviously a good lifestyle. People want that I should be leading a good lifestyle. Then one more important thing which I've come across in various studies, it has pointed out that most of the nurses, specifically from Northeast, it is religion based. So Christians, they tend to migrate more compared to other religions. So it has also, like from Punjab or from North states, and even from Northeast, most of the people, they are Christians, and then they are able to migrate easily. So these are some of the factors or some of the push and pull factors specifically for Northeast nurses as well as in the Indian scenario, which I wanted to highlight. I hope I did not take much of your time.
Thank you very much, Dr. Mawar, for sharing this perspective more from the Northeast. And actually, your contribution brought us back to the beginning of our webinar with the push and pull factors. And you stressed the link to Christianity, which was there very much with the nurses migrating from Kerala, and now is a relevant factor in the out-migration of nurses from the Northeast. Thank you very much. Very urgent statements to be made to conclude. Karin Spannenberg-Krebs from Germany has put a paper in the chat, which was published by the German Platform for Global Health. And this refers to the demands of the German government and the recruitment of nurses from abroad. So we can share this paper, but most of us, we have shared it already among the colleagues at JNU, but we can share it with the others here as well. Any concluding remarks?
Thank you very much for organizing this. It's been fascinating to listen to the other panelists.
Yes, thank you all very much. I would like to say, comparing it to the webinar last week in Ghana, for me, it's astonishing how different the two webinars were, because in Ghana, the most pressing question raised in the end was how to stop the exodus of nurses so that the healthcare sector in Ghana can be saved from collapsing. because it is close to this. And this was in the end the key question in the webinar last week. And our webinar now went into a completely different direction, much more to fair migration and how could the conditions for migration and for migrant healthcare workers abroad be improved. That's interesting, and we will go deeper in this kind of comparison between Ghana and India in our GPN project. And we will ask around among you as well whether we should have a follow-up of this webinar, because there were very, very interesting, insightful presentations here. And I thank you all for the discussion and your questions, and hope to see you at another occasion. Thank you very much. And
thank you, Christa. Thank you.
Nice
As a GPN coordinator based in JNU, on behalf of entire GPN family, let me thank you for this initiative, and to all our panelists for their excellent contribution, the entire team which was supporting you, helping you, in particular Azra, and all the participants who joined us today. I would request you to think of some concrete kind of output, which sort of would be suitable for dissemination, either a few working papers or possibly a book and so on. And hopefully all our panelists would be willing to contribute to that. So that would be sort of celebrating this particular occasion in a more tangible manner. So thank you all. Yes.
thank you very much to everybody, and bye-bye.
Thank you. Bye-bye. Thank you.
Bye.
Thank you.
Yeah, bye-bye to everyone. Bye to everyone. Thank you.